what does the future hold. Here you see the disclosures, and I would like to start with an assessment of structural damage in axial spondyloarthritis. First, radiographic sacroiliitis. It was for years a cornerstone of the diagnosis, and it's still used to classify patients, especially in clinical trials, into radiographic, non-radiographic, and there are even studies assessing a progression of structural damage in sacroiliac joints over time. But you all know how unreliable this method is, especially if assessed by different investigators locally. Then you cannot really say whether it's grade 1, already grade 2, or maybe it's already grade 3. So it's a little bit better for the spine, where we have the EMSA score. Here, the reliability of the assessment is quite good, but the issue with the EMSAs is probably we assess only a small part of the structural damage occurring in the spine. Because here we look only at anterior corners of cervical and lumbar vertebrae, so we completely ignore lateral segments, posterior segments. We ignore other structures like facet joints, costovertebral, costotransversal joints. So we believe that EMSAS is a good proxy for the structural damage in the entire spine, but it might not be true in all the cases. So what we will have in the future? We certainly will be using more and more advanced technologies, cross-sectional technologies, depicting better in a reliable and valid way the entire spectrum of changes in sacroiliac joints in the spine. Here you see an example from the CIMAC study showing you two MRI sequences and one CT sequence. And the question is whether we can assess reliably and validly structural changes using MRI. The conventional, so-called conventional sequences like STIR and T1, they have limitations. Because if you have a lot of sclerosis, it would be really difficult to differentiate between erosions and sclerosis, as depicted in the bottom line of this slide. You see a lot of dark signal. It's hard to say whether there are erosions there or not. And that is why for years we had CT as a gold standard for depiction of structural changes in sacroiliac joints, but it is also possible nowadays with MRI if you use so-called cartilage-sensitive or erosion-sensitive sequence like WIPE or gradient echo sequence. You see a perfect contrast between bone and cartilage, and this is something that is useful for both for daily clinical practice but also for clinical trials. Another recent development is a synthetic CT, so CT-like images derived from MRI with the help of artificial intelligence-based reconstruction. You see here B and C. One of them is a conventional CT, and another one is a synthetic CT derived from MRI. And to be honest, probably you don't see major differences there. So B is a real CT, and C is an image derived from MRI. You have a really great depiction of structural changes there. For the spine, we will probably also utilize more and more CT, and especially low-dose CT. Here you see an example of so-called CS score, so CT-based score for the assessment of structural damage in the spine. And what you see here, if we ignore thoracic spine, for example, as we do with the EMSA score, we're missing a lot of structural damage. We're missing really many syndesmophytes occurring in this area. And as I said, with EMSAs, we evaluate normally only anterior portion, but syndesmophytes, they grow in the entire vertebral body. They can be lateral, they can be posterior, and CT scan, low-dose CT scan is a valid method to assess those syndesmophytes. PET CT has been mentioned already. This is another potential possibility to depict both active inflammation and structural damage, and our hope is that with a depiction of of tissue response, of mesenchymal response, we would be able to capture also the stage between new bone formation and inflammation, something what is not really possible nowadays. Yeah, here you see another example of PET imaging, PET studies, and in this study it was very interesting to see that after successful suppression of inflammation, there was still persisting PET signal in the spine, most likely indicating active process of bone repair in those areas. What about prediction of structural damage progression in axial spondyloarthritis? The issue is we have a variety of outcomes. We have patients remaining on a low level of progression, remaining without syndesmophytes for their entire life, but we have also patients progressing very rapidly, developing within a short period of time, short in axial spondyloarthritis, 5 to 10 years, complete ankylosis of the spine. And we certainly want to identify those patients early, and of course, at the next step, we want to prevent structural damage in those patients. There are several studies which have identified the major risk factors for progression. And these are early syndesmophytes. So if you see a patient already with a syndesmophyte, you know that probably there will be more syndesmophytes in the future. This is high inflammatory activity, elevated CRP, and this is smoking in patients with axial spondyloarthritis. So the question is whether we will have more precise predictors of progression, biomarker, genetic factors, or maybe imaging. One of the new things I would like to bring to your attention today is a genetic determinants of inflammatory response and also of new bone formation. This is related to the fibrinogen and factor 13 system. We have a genetic determination of the density of the fibrin cloud. If the person has a very dense fibrin network, then the inflammatory response is rather low, and with a loose fibrin network, we have high intensity of inflammatory response, and we investigated this also in the context of structural damage progression in patients with axial spondyloarthritis. And what we could find out here, that in patients with so-called wild type of one of the genes determining the density of the fibrin cloud, the predictive value of CRP was very high, as reported previously. So higher level of CRP meant in those patients more structural damage progression. But we had also in this cohort about 1/3 of patients with an alternative allele in this gene. And in those patients, we could not predict structural damage progression in the spine by CRP. So in those patients, systemic level of CRP had no value as a predictor of structural damage progression. We need to keep this in mind, especially for future clinical trials, stratifying, identifying patients with high risk of progression. So what about prevention or retardation? What is clinically relevant for rheumatologists? You remember probably all this data coming from very first trials with TNF-alpha blockers that showed that there is no substantial retardation of new bone formation within the first 2 years of treatment. It was not easy to understand and to explain those data because we postulate there is a direct connection between inflammation and new bone formation in patients with axial spondyloarthritis. So what was the reason for this? Yeah, there are several reasons. Well, one of them, probably 2 years was too short. And second, we had already very advanced patient here, so patients with 15 years of symptom duration with a lot of structural damage in the spine, so it's logical that for a certain period of time, progression went further. There are some data showing that this is probably true. First of all, these data from North American cohort that showed that initiation of treatment within the first 10 years of symptom duration, that is not very early, but still better than afterwards, is associated with less progression as compared to late initiation of anti-TNF treatment, or probably this is true for any effective anti-inflammatory treatment. Then there was very nice work from Swiss cohort that showed that if you achieve, as a patient with axial spondyloarthritis, remission, so low level of ASDAS below 1.3, there will be no new bone formation, no structural damage progression in the coming 2 years. And finally, most recent analysis from the GASPE cohort, we could demonstrate that the effect of TNF-alpha blockade on structural damage progression is not immediate. And this explains very well previous negative results. Here you see what has happened within the first 2 years after anti-TNF treatment initiation. There was no difference between users and non-users of TNF-alpha blockers. But if you look in the following 2 years, so after 4 years, then you see a clear difference. So this effect, if you start a treatment today, you will observe the difference after 4 years, and this is most likely related to this intermediate step of repair and beginning new bone formation that takes time, around 2 to 3 years. There is, of course, a need and a wish to be able to stop new bone formation immediately, right away. You start the treatment, you control inflammation, you control new bone formation, and potentially there might be a role for IL-17 blockade in this context. At least animal models indicated that there might be immediate effect also on osteoblastic activity in this B27 transgenic rat model of the disease. And we also know from clinical trials with IL-17 inhibitors that in comparison to earlier studies where we had 60% of patients with radiographic spinal progression, in these studies, here you see data for secukinumab, only about 20% of patients progressed at all after 2 and 4 years, and the same was also true for ixekizumab. So there was an indicator that the rate of progression under treatment with IL-17 blockers is lower as compared to historical data with TNF-alpha blockers. So the question is, what do we expect in terms of prevention and the retardation of structural damage progression, especially in high-risk patients? So first, results of the CONSOL study, probably you heard that. We see an effect of additional NSAIDs, but in this study it was not statistically significant. Another important and interesting study, this is a first head-to-head study in the area of axial spondyloarthritis, where we compare the effect of secukinumab versus adalimumab in terms of structural damage progression. This is a primary endpoint, and in terms of clinical efficacy, and the results of this study are expected this year. So I summarize here, imaging techniques are important to assess structural damage and disease progression, axial spondyloarthritis, with a range of novel modalities under evaluation. There are some genetic determinants which might affect the prediction of structural damage progression in patients with axial spondyloarthritis. Effect of NSAIDs on structural damage progression is quite variable in different studies, and we expect this year the results of the SURPASS study, where we will see whether immediate inhibition of structural damage progression would also be possible. Thank you very much for your attention, and would be happy to take questions.